Hi, I'm Mike Sonic, periodontist from Connecticut, and I'm here with Dental XP. And I have the pleasure of presenting a case to you all of anterior reconstruction involving both orthodontics, dental implant placement, and some periodontal soft tissue management, periodontal plastic surgery as described by P.D. Miller. This patient who I'm going to present to you today, Sandra, came to see me in her mid-40s, and she was a little displeased with the way her smile looked. She did not like the smile. She did not feel comfortable with her smile. There was dark spaces between her teeth. And when she walked into the room, this is what she felt that she saw. As you can see, there's some darkening tissues, alteration of the soft tissue, teeth in the wrong place, missing teeth. We're not really quite sure what we're looking at when we look at a case like this. So let's take a closer look to see what she looks like up close. Here's her initial presentation. And when Sandra came into our office, she had missing a tooth in the area of tooth number 10 with a cantilever off of tooth number 11. She had a transposed canine. She had what may be a canine or perhaps a deciduous tooth in the area of her canine in the maxillary right area. And it was not a very pleasing cosmetic look for her or to her husband, who said she did not like the way she looked and told her to come in to see me to see what we could do for her. So you can see that tooth number 6 is transposed. Tooth number 7 is either a peg lateral or a deciduous canine that's still in the site of the canine. Tooth 10 is missing. It is cantilevered off tooth number 11. Tooth 11 is the cantilever bridge. So tooth 11 is supporting two teeth, both itself and the adjacent tooth next to it. We also have altered dental gingival margins. If we draw a straight line from canine to canine, what we like to see normally is the central incisors and the canines on that same line. On this line, as you can see, we're coming across the canine, which is in the spot of tooth number 7, and we have the central incisors above that line. So it's not a very pleasing gingival marginal placement or an array of soft tissue. And we also have papilla loss between teeth numbers 9 and 10 due to the fact that tooth number 10 is missing. And lastly, we have very uneven incisal edges. Ideally, we like the incisal edges to follow the wet-dry line of the lower lip and to be sort of like a semicircle. So if we draw a line from the tip of the canine to the other canine, you like the tips of the teeth to sort of fall on that line as we go along the radius of the arch. In this case, they're very uneven, they're not very clear, and it's unesthetic. So what I like to do when I look at these type of cases is I like to develop a problem list. I like to say to the patient, well, this is what's wrong. And I say to the patient, also, what do you think is not right? So it's a time for me to look at everything that the patient has and say, well, I don't like this, I do like this should be here, this shouldn't be here. And when I was in India about 10 years ago at an aesthetic conference, I learned a concept, and I brought it back from India that I took back. The conference was called Aesthetic International Indian Conference, a study of pink and white. And what they did very simply was they drew on these cases where they would want the white to be, the teeth, the enamel, and they drew where the pink should be. And if we could sort of take an artist's paintbrush and draw where we'd like the soft tissue to be and where we'd like the white tissue to be, the hard enamel, it sort of defines how we could set up this case. So when we look at a case like this, I start to give myself a wish list of what I would like to do if everything could be done ideally. So that is called our treatment plan. We've identified what's wrong, which I call the aesthetic diagnosis. Now we have to come up with an aesthetic treatment plan. Now that aesthetic treatment plan may involve orthodontics, it may involve prosthodontist, it may involve dental implantology, it may involve periodontics, periodontal plastic surgery. It can involve all the disciplines of dentistry as we know it. So let's take a look at this case, and let's try to figure out as a group what we would like to do if we wanted to make this patient look ideal. So here's the side view, the lateral views in the canine, and you can see very clearly where we've lost the soft tissue between the central incisor and the lateral incisor where the tooth is lost. And you can see the altered dental gingival margins. You can see the discoloration of the teeth, where we have a very yellow retained deciduous tooth or canine in the area of the upper right canine. You can also see the opaque porcelain that's not very aesthetic. And now we have to define our treatment plan. In this case, what we decided to do was evaluate the patient and get rid of the peg lateral. That was not a very good tooth to support anything. We did not feel that would add anything to the case. Plus, the canine was in the area of the lateral, and ideally we like the canine to be in the position of that peg lateral. So what we did is we decided to get orthodontics involved, and ideally we wanted to distally move tooth number 6, which was in the lateral spot, to put it where tooth number 6 is. We also would like to create 2 lateral incisor spots. So in the lateral incisor spots, we would then replace those with either implants or with prosthetic replacement for Pontics. And then also, the orthodontics would allow us to align incisal edges. So with ortho, we're able to get distal movement. We're able to create 2 recipient sites for teeth in the areas of 7 and 10, and also able to align our incisal edges. Once the orthodontics was completed, we're allowed to then place implants in the areas of 7 and 10. We'll then allow the implants to heal. Once the implants heal, they would be uncovered, they'd be exposed, and then we would perform crown lengthening. I don't like to perform any aesthetic crown lengthening until the implants are uncovered, because that allows me to determine where the soft tissue is going to be around the implants. That way I can mimic ideal harmony in relationship to the implant soft tissue sites that's already created. So I don't like to set up the case until after the implants are integrated, and when I'm convinced I know where the soft tissue is going to be around the implants. So crown lengthening will then be done. And once that is done, I'll send the patient back to the restorative dentist for provisionalization. And after provisionalization, we'll then do our final prosthetics. In this case, it would be crowns in 7, 10, the 2 implants, and tooth number 11, which already has a crown, and veneering tooth number 6, which we've now moved from the lateral spot back to where it should be in the area of tooth number 6, in place of veneer on tooth numbers 8 and 9. So, we've come up with our aesthetic diagnosis, we've now come up with our ideal treatment plan, and now what we have to do is just carry out the plan. So it's sort of like an architect. You make your diagnostics, you do your testing, you determine where things should be, you create a plan, and now you just got to bring in the various subcontractors to carry out your plan. Whether you do your own orthodontics yourself, or you send the patient out to an orthodontist, it doesn't matter, just as long as the right people are doing each of the proper jobs. So then we'll go ahead and create the treatment plan. First step is to get out the lateral incisor, which appears to be in the canine spot, and then go ahead and perform orthodontics. We began this case in February of 2000. Approximately a year and a half later, in September of 2001, we were able to distally move the canine. One of the nice things about moving a canine distally is that because there's bone around the canine in the area of the lateral, once that canine is moved distally, the bone will stay there. And this has been shown by many people, including Vinny Kokic out of the University of Washington in Seattle. So the case is now sort of set up and ready for the next phase of care, which would be implant therapy. It took us just a little bit over a year and a half to complete the orthodontic therapy for this patient. Teeth were moved slowly, and so that would not cause any root resorption, and the orthodontist in this case did a very nice result. So, movement of the canine distally from the lateral space does leave bone for implant treatment. And here you can see the before and the after of the movement of the canine distally. Here we've highlighted the canine in gray before treatment, and now we've highlighted the canine in gray after treatment, and you can see the amount of bodily movement we were able to get with this canine. Orthodontics is now complete, and we're going to go through the next phase of care, which will be implant therapy. Implants were placed, and we do have enough space necessary for dental implants. Ideally, I like to see about 1.5 millimeters of space between the implant and the adjacent teeth. Since the implants that we have, the smallest ones are about 3.25 millimeters, I like to have about 6.5 to 7 millimeters of space as a minimum to place implants in the lateral incisor area. And that space should be carried along the entire root length. If you look at the CEJ for a lateral incisor, if you have about 7 millimeters in that area, you like that 7 millimeters to be carried up all the way to the apices of the teeth, or to the extent of that distal extent of the implant. Apical extent of the implant. So you don't want the roots to move closer together as you move apically. You want enough room to do that. Here we have placed our implants, and we're now going to go ahead and expose the implants. And you can see that bone grafting is not necessary. We have a tremendous amount of bone that has that is present in the areas of the lateral incisor, especially the upper right one. And the reason that that's the case is because this patient had the canine move distally from that spot, and you can see the amount of bone that we have. We exposed the implants and then did a little crown lengthening in order to get a harmonious dental gingival angle. And then we pushed the tissue from the palatal toward the labial to sort of bulk up the tissue over the implants. Did a little bit of a roll technique out of Lenny Abrams, and we have a tremendous amount of soft tissue in that area, so it looked like the implants actually have roots. And one of the things that I frequently see with dental implant placement, especially in the lateral incisor area, because you have that little concavity in the canine fossa, is that it looks like you don't have the root prominence. One of the ways that we get around this is by overbuilding the bone. In this case, we had a lot of bone because the canine was there on the upper right, and on the left side, we just happen to have a lot of bone for this area. But I also, at second stage of surgery, I don't want to lose the opportunity to move that soft tissue from the palate labially. By moving that tissue from the palate to the labial, it's a way to do a connective tissue graft without having to go to the palate and getting connective tissue. And it's an area where a lot of surgeons miss the opportunity. They'll do a punch technique, they'll do a mid-crestal incision. All you have to do is move that scalpel 4 or 5 millimeters to the palate, even further if you want, as long as you don't go down into the rugae, and take that tissue and roll it labially. It's a very simple technique, and it was done by Lenny Abrams many, many years ago, and then talked about by Dr. Garber and Salama in many of their presentations. And it's a technique that I've been using routinely since I've been doing implant dentistry for single teeth, something 17, 18 years ago. Very simple technique, but a lot of surgeons sort of miss that one, but it's a very easy one. So here we go ahead, and we're using a couple of 2 millimeter Gelb gauges to define where our implant should be placed. If you look closely at the x-ray, you can see the x-ray on your right, the patient's left. The Gelb gauge looks pretty good. It's far enough away from the teeth. We have our zone of safety. One of the things you don't want to do is you don't want to put your implant in and impinge upon the periodontal ligament. If you get too close to that periodontal ligament or nick it, you can cause endodontic failure of the adjacent tooth, which could lead to endodontic failure of the tooth, or worse, loss of the tooth. And when you're replacing a tooth with an implant, the worst thing that could happen is to lose the adjacent tooth because you put the implant in. I mean, you're trying to do something to make the patient better. As they say, in the Hippocratic Oath, above all, do no harm. You don't want to make the patient worse. If you look at the contralateral radiograph, you can see that Gelb gauge is a little close to the canine, too close. So one of the reasons that I always take a check x-ray, no matter how many implants I've done and for how many years I've been doing it, I always check x-ray with single tooth implants, as I want to be sure that my implant is not going to impinge upon adjacent teeth. In my experience, one of the most difficult implants to place is the single lateral incisor, because as an operator it's very easy to think that you're going parallel to the root surface, but especially for a right-handed operator you tend to angle that implant back towards you. So I'll take the check x-ray, and I'm often very surprised that my implant is not where I think it is. So what we'll do is we straightened out the implant, and now we placed it parallel to the roots. As you can see, we straightened that out, but we both used 3.25 implants for both of these, and we provisionalized them in this radiograph. Then the next phase of care is provisionalization. At this point in time, the patient has had orthodontic therapy, the implants have been placed, we've done crown lengthening, we have a nice soft tissue harmony. The canines and the central incisors are at the same level. The lateral incisors are about 2 millimeters beneath that. I like to have about a 2 millimeter difference between the height of contour of the centrals and canines and the height of contours of the lateral. And that way, it's a nice pleasing harmony. Coyce talks about it as high, low, high, going high to the canine, low to the lateral, high to the central incisor, and then high, low, high again, high to the central, down to the lateral, and up. It doesn't have to be that way, but if you're going to redesign it, that's the way I usually design these cases. And if you look closely at the soft tissue, you can see that it looks like there's a root prominence over both lateral incisors because we bulked up the soft tissue in that area. So the provisional is done, and this was done about 6 years ago, and it's a good provisional. It's not excellent, but it's a good provisional, and it seems to fit the teeth pretty well. Here's the laboratory work, and one of the things that you can see is that one of the implants is a little deeper than the other implant. And ideally, we probably should have dropped that implant down a little bit more. The ideal position in an occlusal apical direction for a dental implant should be about 3 millimeters from the anticipated free gingival margin. Not the adjacent teeth, not where you think it should be, but but where you want that soft tissue to be when the case is done, you want that implant to be about 3 millimeters from it. It allows you enough room to develop what we call running room, as talked about by Steve Potashnik, so you can get a nice emergence profile. It also is deep enough so that if we get any recession, you're not going to show the top of an implant. Because as people have said, you have one opportunity to get your implant in the right spot. And if you place that implant, too close to the free gingival margin, and you get a little recession and you show the head of your implant, there's not much we can do to cover the soft tissue of the implant. And it becomes very difficult to save an aesthetic failure when the top of the implant is being shown. So if anything, I would err on placing the implants a little too deep instead of too shallow. And a shallow implant can't be corrected too easily. So here's the provisional restoration, and soft tissue profile is good. The implants have integrated nicely. At this point in time, I'm happy. I will send the patient back to the restorative dentist. In our practice, I'm a periodontist and implant surgeon. I don't do restorative dentistry. The restorative dentist relies on me to say when the tissue is stable, when they can go to the final impressions. At this point in time, we have papillas present. Everything looks good. I'll send the patient back to the restorative dentist. And here's the final restoration. If you look at that slide closely, you can see that the final restoration is a recapitulation of the provisional restoration. There's not much difference in where the soft tissue is. I'll go back again. Here's the provisional restoration. Look closely as the slide morphs into a final restoration. You can see that the soft tissue doesn't change. Okay? The final restoration is completed, and the final restoration has 2 crowns on the single-tooth implants, a crown on the upper left canine, tooth number 11, and veneers on the other 3 remaining anterior teeth, namely number 6, 8, and 9. And we have a nice soft tissue profile, good harmony, papillas are there, and everything looks pretty nice. So I'm pleased with the way this case looks. Also, the height of contour over the lateral incisors is directly over the middle of the tooth. It doesn't go labially, it doesn't go mesially or distally. It's directly over the center of that tooth, where it should be, because that's where the implant is, right in the middle of that tooth. So here we're looking at the before situation, the canine in the wrong spot.